My name is Johan. I'm the program manager of the antiretroviral treatment program at the South African Catholic Bishops' Conference. The ARV treatment program started off at the end of 2003. With funding that we got from court aid, we were able to start providing ARV treatment in 5 sites. The following year, in 2004, we managed to get mp4 funding, which is US government funding, and then we were able to use the experience that we had acquired in those 5 sites to expand the program, so that eventually we ended up having 22 ARV treatment sites. The approach in delivering that service is that firstly we tried to find places where the government at that stage was not providing ARVs, and we tried to find places where it was unlikely that the government would provide ARVs. We focused specifically on rural areas, on informal settlements, and on the most deprived and marginalized communities. And we didn't have clinics or hospitals through which we could provide the services. So our basic approach was to use church infrastructure to provide services. In other words, women's organizations of caregivers. We use church buildings as, call it treatment centers if you want to, where people came to get the services. We provided training, we provided human resources. Every site we provided, for instance, with a medical doctor, a professional nurse. We provided training in financial management, in counseling, in all sorts of things. So in a nutshell, I would say our basic approach was to use church infrastructure and church people to provide the services, not professional settings like clinics or hospitals. At the moment, patients that are on antiretroviral treatment would be about 18,000 countrywide. Yeah, we have a OVC program which is also funded by mp4. The OVC program, we have 33 sites throughout the country, with approximately also about 16,000 orphans receiving services. A wide range of services. We give them access to education, we provide them with clothing, we provide them with food, we provide them with access to medical care, we provide them with HIV testing and with ARVs if necessary, we provide them with legal services, official documentation, we provide them with psychosocial services. The idea is that out of this whole menu of services, every orphan should receive at least 3 services. So in other words, you don't have some who are just getting food parcels and others who are just having their school fees paid, but every orphan should receive at least 3 of the services that I just mentioned. The first US government mp4 grant, that period was from 2004 until 2009, and of course the program was worldwide and there were many organizations that were funded, but with the first mp4 grant, most in-country organizations were funded in partnership with a US-based NGO, big American organizations. With mp4 2, that's now the mp4 funding for the period from 2009 until 2014. The American government said that funding had to transition to local partners, in-country partners. In other words, not in partnership with big American organizations. And of all the hundreds of mp4 programs worldwide that are funded by the American government, our antiretroviral treatment program was considered to be the first one that had such good capacity that with mp4 2 we were the first in-country partner to be funded directly by the US government. And I think that was a highlight, to think that we had managed to build a program of such good quality that the American government said of everything they funded worldwide, our program was the first one to be funded directly by them, not through an American organization. That was a high point. Well, the first outcome that we are very proud of is the fact that we have 18,000 patients on treatment, and our program has been monitored by a professor from the University of Cape Town. He evaluates the data, and according to what he has seen, our adherence rates based on viral suppression and that type of thing is about 96%, which is very, very good. Most programs elsewhere in the world consider themselves to be fortunate if they get adherence rates of 50%. Just the fact that we've managed to save so many lives, because if you think 18,000 people, they all would have been dead if we hadn't been able to provide treatment for them. And of course, it's not just 18,000 people. They have partners, they have children, they have dependents, so the knock-on effect is much, much wider. That's the first good thing. And I think what's also been good is how we've managed to build capacity in church networks. You know, people often think the church is just good for going out to pray with the sick and so on, but professional services and programs, that's an area that they shouldn't venture into. And we've proven that with building sufficient capacity, providing enough training, etc., etc., a simple rural parish in a deep rural African place can provide sophisticated and sort of advanced, complicated programs like implementing an ARV treatment program. That's a far cry from the days when what the church did was just old women who went to a house to pray with the sick and to make them a cup of tea. We have shown that with proper resources, training and capacity building, the church can provide a level of professionalism and quality services as good as anyone else. I would say the most important lesson is that we've learned the church can do it. You know, that is important, because in the past people always assumed, just to give you an example, when we started with Cord Aid funding to do our first 5 ARV treatment sites, we used home-based care organizations based in parishes in very, very poor areas. And we did an internet search to see what lessons we could learn from somebody else. And we've discovered that there was nothing on the internet. And then we realized that up until that point, 2003, ARVs had always been provided in a clinical professional setting, a clinic or a hospital. And we showed that the church can do it using church infrastructure, the commitment of your people, and so on, the wide reach of the church. You can provide quality services. I think that was the most important lesson we learned, that the church is really the perfect vehicle for service provision to deprived communities in remote area, because there's no other institution that has a reach as wide as that, not even the government. Well, the biggest vision and what I would like to see is something that's going to be extremely difficult to realize, and that is, at the moment, most of our programs are completely dependent on donor funding. And what I would like to see as a vision and as something going forward is to somehow to get all of these programs to be able to support themselves. That's a pipe dream. It's going to be impossible, but it's something that we would have to